Good afternoon, friends. I'm Dr. Gaurang Kumar, basically joint replacement surgeon. I recently developed interest in arthroscopy. So it's not a very big presentation. It's pros and cons in direct anterior approach. I will not go into the surgical procedures, but I'll tell you the rough idea how it's done and what is the major and main benefits of the direct anterior approach. As I am working with Dr. Karthik Patel, I am fellow there. I am learning right now this anterior approach. So I added his name also. We do this all in Shaja Orthopedic Hospital.
आपको करना
Okay. See, nearly everyone has some major or small idea of what is anterior approach. It's minimally invasive with muscle sparing technology in total hip arthroplasty. And management of the patient for this anterior approach requires placement of the patient on a table which can do hyperextension as well as adduction while fixing up the pelvis on the contralateral side. For that, we usually in foreign countries they use HANA table, but we can do it on normal routine table or fracture table as well. We just have to flip the table upside down. So wherever the center point where we can do the hyperextension. So patient's head will be opposite side. We rotate the table and we can do hyperextension. And in HANA table actually there are particular leg which can go inferiorly, superiorly, medially, laterally. But in this we can do figure of 4 in hyperextension. So can be easily visualize the femur entry. So surgical plane we start incision from the tip of ASIS. From the tip of ASIS 2 centimeters below, 2 centimeters lateral. From that point we go in the plane of lateral, inferiorly and laterally to the fibular head. So we have to put an incision in between the belly of the TFL muscle. So once you find out this TFL, you just palpate, you will see the bluish area. When the superior belly ends and the TFL belly starts, there are bluish area which is your landmark. And you put an incision sliding with the scissor, and you can slide down the whole TFL muscles inferiorly. You slide out inferiorly and you can see the lateral circumflex arteries, vessels, which we must like it, otherwise it will bleed a lot. It will give you a hell of the wastage of the time. Then separating the fascia with the anterior capsule, you can see there is anteriorly rectus femoris, which you have to elevate to the anterior side and the TFL belly to the inferior side. Then you easily can see the joint capsule. And in the joint capsule, we have to do capsulotomy in the T fashion, or somebody use the I fashion, whichever you like. And you can easily see the femoral head. Before the cutting the femoral head or delivering the femoral head, we should do the dislocation. So you can, after the cutting the femoral head, you can easily deliver it. Okay. So after cutting the femoral head, the inferior capsule is the pubofemoral ligament is attached. It should be and it must be divided, and then you go for the superior capsule. Superior capsule you cut horizontally till you can see the fat pad. That is your landmark. If you do not cut or less cut the superior capsule, you won't be able to lift the femur. You can be visualize and you can prepare the femur for the stem component insertion. So this is the basic plan. This is the TFL muscle. We put incision here. This TFL muscle will be pushed inferiorly, and the rectus femoris will be anteriorly, and you can directly see the capsule. See the advantages of PA. The major advantages is there is no chances of LLD. I write less, but there is actually no chances of LLD, limb length discrepancy, because the patient is in a supine position, and you can manually, clinically also see the both medial malaris for the limb length discrepancy, as well as you can see in the IITV guidance both the LTs. You can compare it after the trial and you can do it beautifully. Sometimes if the both hip are inward, so some little half centimeter or 1 centimeter of the lengthening is acceptable, because you wanna operate on the opposite side later on. So we have to keep it in mind. So we can match the both limbs accordingly. There is less chances of dislocation, but recent material also says there are similar chances of hip dislocation, like 1.2 to 1.3%. But we never seen dislocation after the anterior approach. I have never seen till date. Less postoperative pain because we do not cut the muscles, we just tear it. No muscle will be cutting during the surgery. Thus the faster recovery. Component positioning better under the IITV guidance, which I will show you in the next slide. As a patient in the supine position, you can see the IITV and you can see the femur acetabular component into the IITV. You can check the version, anti-version, inclination, and the rotation, center of the rotation. Everything you can see easily, which we cannot see in the posterior approach or traditional approaches. Early mobilization, shorter hospital stay, and this is important, fewer post-surgical precautions, because you don't have to tell them put the both knees in adduction or whenever we shifting the patient, we have to be very careful in the traditional approaches. But in this approach, we don't have to worry about any kind of these complications. See, this is the intraoperative video I have taken, which will show you when you ring the acetabulum, okay? So your cup should be like in a parabolic shape. See, if it is not in a parabolic shape, your anteversion is not good, and you can easily see the inclination. So it won't be in the vertical position or something like that. See, this is a parabolic shape. Okay, good, and getting it. It's a parabolic shape. So the anteversion is like 20 degrees. You can easily, it's a landmark. If you do not know in the deep, if you have your cup, your rim in a parabolic shape, you are doing good. Especially another advantages of direct anterior approach is, can I go there? Whenever we have the protrusio or the dysplastic hip or the ankylosed hip, okay. So when you are reaming, you have the idea where your wall ends. So knowingly and unknowingly you won't break it, and you can always save, and you can always save your this wall, and you can go further. This only can be done in the anterior approach. While you doing it under IITV fluoroscopy, you can prevent it. You can't go further because you have the idea where it ends. See, this is the preoperative case. We have separated so much bone here, and you also have the good placements of screws where it goes. There are few disadvantages. It requires special instruments like Anna table, but we can do it in a normal table also, as I already explained. You have good assistants, and you need a little bit of good retractors, what we say. But this can easily manage in India. One must master the technique. It's a time-consuming thing. Whenever you see the videos, it looks very nice, very easy. You say, oh wow, we can do it in 30 minutes. But initially it took us 2 hours, 2.5 hours, like that. So one must master the technique. Patient selection, obese and very muscular patient are not a very good suitable candidate for the surgery, as there is a lots of muscle belly or the lots of fat. We cannot visualize because it's a very small incision, 3 to 4 inches incision is there. So we cannot visualize the operative field properly. There are reported wound healing issues is 1.3%, I rather say 1%, but it doesn't require any medical attention because it's a superficial only, and it's because it's very near to the our pubic and this yeah. So it does not require any medical attention. One more thing I would like to add, this lateral cutaneous femoral nerve also passing through this plane also, and the damage of this nerve is very common, but it does not lose your strength of the muscle or the functioning of the muscle. It will just give you the like paresthesia like sensation it will go in 6 to 8 months. So other than that, there is no that huge disadvantages of the anterior approach. That's all. Any questions?